Hello and welcome to the VJ Hem-Onc podcast, where we will be sharing some of the biggest updates in multiple myeloma from ASH 2025. This episode will cover several key trial updates, including the RedirecTT-1 and MajesTEC-3 trials, as well as some novel approaches, such as BCMA CD19 dual-targeting CAR T-cells, and a next-generation tri-specific antibody. This podcast is part of the Multiple Myeloma channel on VJ Hem-Onc, which is supported by BMS and Legend Biotech. These supporters have no influence over the production of the content. This podcast is intended for healthcare professionals only. So, without further ado, let's hear from our first speaker, Luciano Costa, who discusses redefining functional high-risk myeloma in the context of upfront quadruplet therapy and autologous stem cell transplantation.
So in the era prior to anti-CD38 monoclonal antibodies, we embraced the notion of functional high risk as a definition for patients who have disease progression, either within the first 18 months of treatment or first 12 months after transplant, to indicate a group that doesn't do very well in subsequent line of therapy, irrespective of their cytogenetic risk. And that definition was carved around the notion that the overall survival for those patients with subsequent therapy was inferior to 2 years. Now, with quadruple induction and consolidation autologous transplant, the prognosis for patients with newly diagnosed myeloma has greatly improved in general. So fewer patients are having progressions. However, it's important, is not too far of a stretch to hypothesize that those who do progress despite this therapy have a more, biologically aggressive disease. So we need to reconsider what the optimal timing is to call functional high risk in the era of quad and transplant. So we use a data set, again, of over 300 patients, all treated with quadruple therapy and autologous transplant, and post-transplant consolidation and maintenance to interrogate what was the best cutoff. And the bottom line is the 36 month defines a population that with progression before 36 months have a subsequent overall survival of 2 years. It was actually 23.8 months. So we propose that in this modern era, we should consider functional high risk anybody progressing with the first 36 months. And that has implications for, describing cohorts or patient population in clinical trials. Now, we took advantage of this data set to also interrogate how those people do with subsequent therapy. And overall, there was a lot of use of carfilzomib, pomalidomide, reuse of anti-CD38 monoclonal antibody. So those patients received, the best available therapy. But some of those patients receive a T-cell redirecting therapy, either a bispecific or CAR T-cell, at the next line of therapy, either through clinical trial participation or more recently through the availability of cilta-cel in second line. And what we found is that in multivariate analysis, we even factor in the functional high risk at 36 months and cytogenetic risk. The functional high risk at 36 months remains predictive of worse response, worse progression-free survival, and worse overall survival. But the T-cell redirecting therapy is strongly associated with better progression-free survival with a hazard ratio of 0.17. So I think that is, again, another piece of data that puts in perspective how high risk those patients are, despite having only one prior line of therapy, and suggests that the use of novel agents, particularly T-cell redirecting therapy of some capacity, can perhaps modify the natural history of this otherwise very deadly condition.
Next, you will hear from Nisha Joseph, who speaks about a phase 2 dose optimization study of inobrodib with pomalidomide and dexamethasone in relapsed refractory myeloma.
This is a phase 2 dose optimization trial looking at the combination of inobrodib, which is an oral P300 inhibitor, in combination with pomalidomide and dexamethasone. And importantly, this drug was shown to have synergy with these immunomodulatory agents in preclinical models, as well as additional earlier clinical trials. What was really exciting about this trial is that it included very heavily pretreated patients. So patients that had, of course, multiple lines of therapy. Many were pentaclass exposed and are refractory, but also 60% of patients or so had also received a prior T-cell engager. Several patients had also received prior CAR-T and prior antibody drug conjugate. So this was a very heavily pretreated group of patients who really had exhausted standard therapies. So inobrodib was given in combination with pomalidomide and dexamethasone at 3 doses, 20 milligrams, 30 milligrams, and 40 milligrams. What we saw, even in this very heavily pretreated population, was very encouraging overall response rates ranging from 40 to 60% across these dose levels. This is an all-oral regimen. This was relatively well tolerated in terms of some of the adverse events that we were seeing. A majority of those were hematologic cytopenias that we see commonly in this patient population. Outside of cytopenias, we were seeing very tolerable side effects in terms of fatigue, some GI side effects, non-neutropenic fever. Infection rate was not particularly high. So again, a pretty well-tolerated regimen in this heavily pretreated population. And importantly, when you look at severe treatment-emergent adverse events, these were higher at the 40 milligram dose. So when we looked down at the 20 milligram dose, we were still seeing good efficacy without such high rates of AEs. And so moving forward, the plan is to move forward with the 20 milligram dose. So I think really encouraging result for an all-oral regimen. I think in this era of, we have so many, we're so fortunate to have so many really effective T-cell engager therapies, but we know that we can't really do these therapies effectively back to back. There's still an unmet need for effective, well-tolerated therapies that we can use post T-cell engager, or maybe even in between T-cell engagers. I think this is a really important space potentially that inobrodib could fill. And we're looking forward to the Domino 1 study, which will be a phase 2 study looking at inobrodib at 20 milligrams in combination with pomalidomide and dexamethasone.
Now we will move on to some updates regarding CAR T-cell therapy. Shambavi Richard will comment on preliminary results from the phase 1b/2 trial of AZD0120, a BCMA CD19 dual-targeting CAR T-cell therapy. Krina Patel will then share updated results from the phase 2 Imagine-1 trial of anito-cel. This is followed by Samir Parekh, who shares insights into the earlier use of cilta-cel from the CARTITUDE-4 trial.
Yeah, I'm excited to present the early results, the preliminary results of the phase 1b Durga 1 study. This is a safety and efficacy analysis of patients who have had at least 3 prior lines of therapy and are triple class exposed, so a notoriously difficult group of patients to treat. This is a novel CAR-T product that targets 2 antigens, BCMA and CD19. BCMA is universally expressed on the majority of malignant plasma cells. CD19, on the other hand, is widely expressed on various phases of B-cell development and on some subsets of myeloma cells and progenitor cells. Also, in addition, this particular product has a different manufacturing platform. While traditional manufacturing takes several weeks for the CAR-T cells to be made, this particular one is on a FastCAR platform that manufactures CAR-T cells in less than 3 days, making it potentially available to more patients who need the CAR-T. In addition, because the bulk of because the ex vivo manufacturing is eliminated, so these cells just go through activation and transduction, and the expansion is completely in vivo. So the CAR-T cells that are made are younger and fitter and more naive. And so only a small cell dose is required, and that improves the safety. So in fact, when we looked at the safety data, the majority of adverse events were hematological. While 80% had neutropenia, this was short-term. The thrombocytopenia and anemia were much less. There were no deaths or dose-limiting toxicities, and infections were very low. Less than 10% had grade 3 infections on this study. In terms of CRS and Icahns, the CRS rate was only 62%, only 46% required tocilizumab, and of the 16 patients on this 26 patient study, 15 of them had grade 1 CRS. So there was only one grade 2 CRS. In terms of Icahn, there was only one grade 1 Icahn events reported in the entire study. There were no delayed toxicities, no delayed neurotoxicities, no Parkinson's disease or Guillain-Barré. There was no cranial nerve palsies. There was no IEC-associated colitis. So really a very well-tolerated CAR-T product. And in fact, a third of the patients received the CAR-T infusion as an outpatient. So in terms of the efficacy, the short follow-up, the median follow-up is 3.9 months, but 96% was the response rate. 78% were CR or better. 17% were partial response. And in the MRD valuable population, 94% were MRD negative. And all of this happened in the first month. So we're very excited to look ahead to more updates on this study, both in terms of toxicity and particularly in terms of efficacy. I think this is something to follow.
We got to present these updates at ASH 2025. And of course, this was our pivotal phase 2 study for patients with relapsed refractory multiple myeloma. And patients had to have been triple class exposed, so to a PI, IMiD, and anti-CD38. And the data cutoff for this presentation was October 7th, 2025. And so in general, or in total, there were 117 patients that actually got anito-cel infusion. And so the median follow-up for those patients was 15.9 months. And basically all of the patients received anito-cel at 115 times 10 to the 6th CAR positive T cells. And here I'll say that one of the differences between anito-cel and some of the other CAR Ts that are already out there for both or lymphoma, myeloma, leukemia is the scFv. So the way that the CAR T attaches to the target on the myeloma cell, it's not a classical scFv, and it's actually something called a D domain. Basically, it's a protein, a really small protein. And because of its size and the way it works, you can actually get a much better efficiency of CARs into the T cells. And so, again, our target dose of cells is actually lower than most other CARs out there because most of the product is CAR positive T cells. There's also a thought that maybe the way that protein works, it comes off the target quickly, like has a fast off ramp time as well. And maybe that decreases inflammation as to why maybe there's less side effects and a better toxicity profile for our patients. So, in terms of the efficacy, we were able to show that there's still a great response rate of 96%, but we're seeing a deepening of that response. And so the CR and stringent CR rate was actually 74% and the VGPR better 88%. And then we were able to show a lot more MRD data, which was exciting because, again, in CAR-T in general, we know that patients who get to MRD undetectable quickly tend to be the ones who get a really long-term PFS. And then more is the sustained MRD. And so for our data, there were 96 patients that we were able to get data for that were evaluable, and 95% of them were actually MRD undetectable at 10 to the minus fifth. And then there are about 65 patients that had enough follow-up and repeat bone marrows that we were able to check 6 months or more later. And 83% of those patients were actually still MRD undetectable at 10 to the minus fifth, which was great to see. And then, of course, PFS, we don't have a completely calculated PFS yet. Our last patient that's been treated was just about a year ago, but our 18-month PFS was 67.4%, and our 24-month PFS rate is 61.7%. So, again, hoping that future data will show us that maybe we're starting to have a plateau. We don't know yet, but I hope that's the case as it has been with a couple of our other CAR-Ts. And again, median PFS overall survival not reached. The other big, update was the safety. And again, since our last discussion of this data at our last presentation in summer, no other toxicities, treatment-related, serious adverse events or anything. And we haven't seen any of the delayed non-Icahn neurotox like Guillain-Barré or Parkinsonianism. We haven't seen cranial nerve palsies, and then we haven't seen any of the IEC colitis. And again, our last patient was about a year ago treated. So, we would hope that if that was going to happen, we would have seen it now. But of course, we're going to keep watching these patients. So again, just really great, depth of response that we got to see the MRD, the, calculated PFS, as well as the safety data that I think really helps us hopefully get more access to CAR-T for more of our patients. 8% of these patients, I forgot to mention, were actually outpatient. And I'm hoping with MajesTEC-3, the phase 3 study that's next, we'll be able to do more outpatient now that we know a lot more about it, about the CAR T. But this is what will, I think, really help with getting more access, not just hospitals like us that can do CAR T, but letting other hospitals be able to do it with the resources they have and to do it safely, I think is really important. And hopefully will again increase the ability for our patients to get this great therapy.
I presented on the earlier use of cilta-cel and its correlation with better immune fitness from correlative data presented from the CARTITUDE-4 study. And just to set the stage, CARTITUDE-4 is a clinical trial where patients were randomized to either standard of care or CAR T after receiving 1 to 3 lines of therapy, and they needed to be lenalidomide refractory at that stage. About 80% of the patients had gotten an autologous transplant. And in contrast, CARTITUDE-1 is a study for later lines of treatment where patients had at least 3 or more lines of treatment and were both refractory to proteasome inhibitors and Revlimid. The outcomes of both trials have been some of the most exciting results of the year. The long-term follow-up of CARTITUDE-1 has actually shown a third of the patients are relapse-free and treatment-free more than 5 years, which is really exciting for this population. Similarly, CARTITUDE-4 has shown that treatment in earlier lines of therapy results in durable outcomes and in fact outperforms standard of care, both in progression-free survival as well as overall survival. The new data that I presented showed that we now have follow-up indicating that treatment in 1 or 2 lines of treatment is even better than treatment in 3 or more lines. As an example, the progression-free survival was significantly better in patients that got 3 or more lines versus exactly 3 lines. That was 34 months versus 50 months. And in the patients that had 1 to 3 lines, they haven't even reached the median progression-free survival. Overall survival, similarly, even in patients that received similar prior treatment, had similar disease burden, age, and other clinical characteristics, was better in 1 to 2 lines versus more than 3 lines. And this raised the hypothesis that the patients in earlier lines may have a better immune fitness that supports CAR T durability. So to test this, we took bone marrows from prior to treatment, day 28 and at 6 months, and also looked at TCR sequencing and gene expression from these studies. We also looked by flow cytometry at pre-treatment peripheral blood, and both of these showed a striking pattern. The bone marrow showed that there was robust anti-tumor myeloid cell activation. For example, M1 macrophages and neutrophils were degranulating as CAR T expanded and killed the tumor. There was across-the-board T-cell activation and better antigen presentation when patients were treated in earlier lines of treatment. And perhaps the most important evidence was higher CD4 naive cells, which have been shown to be associated with durable responses in patients that have received anti-BCMA CAR Ts of different types. So the patients that had higher CD4 naive cells actually did better in terms of progression-free survival, as well as they were numerically higher in patients that had prior lines of therapy with either 1 or 2 lines as compared to 3 or more. Overall, this suggests that prior lines of treating patients with CAR T in earlier lines of therapy is associated with better immune fitness and better progression-free survival and overall survival. And this is, I think, going to change the paradigm where we now counsel patients regularly, but the message has to go out to the primary practitioners that see these patients in the local communities that a CAR T is indeed a superior option for these patients relapsing after 1 or 2 treatments, and they should try to offer it to them.
Next, you will hear about recent advances with T-cell engagers in multiple myeloma, starting with newly diagnosed patients. Salomon will discuss a trial of teclistamab plus daratumumab in older patients with newly diagnosed myeloma, followed by Dickran Kazandjian, who shares insights into the immunoplant study of linvoseltamab immunoconsolidation in newly diagnosed myeloma.
Yeah, so we reported the IFM 2021-01 TEC-Lille study at ASH 2025. And so it's a phase 2 study dedicated to transplant non-eligible patients. And they received the combination of teclistamab and daratumumab and all antibody regimens. So patients were transplant non-eligible, 37 patients were included, and they received the monthly schedule of teclistamab and daratumumab with the regular schedule. So what we see in terms of efficacy is that at best response, all patients responded and all patients had a VGPR or better, with most of the patients achieving a complete remission. We evaluated MRD for all patients at 6 months, and we observed for evaluable samples a 100% of MRD negativity at 10 to the minus 6 by NGS. There was no events of progression or death in the trial with this 10.3 months median follow-up, so the rate of PFS and OS are 100%. And what was interesting is for the safety profile, the concern is always the infections with the bispecific antibodies. And here we had a strong recommendation for systematic immunoglobulin prophylaxis as soon as cycle 1 for all the patients in the trial. And this prophylaxis was actually well followed. 95% of the patients actually received this prophylaxis of immunoglobulin at cycle 1. And the rate of grade 3-4 infection is 14%, which is quite good. And what we can see is that with this prophylaxis, we're able to maintain the IgG level at a level around 7 grams per liter across the course of the treatment. So I think this strategy is well preventing the risk of infection. So overall, the combination is highly effective and the safety profile is very good.
The idea of the immunoplant study is really to use our new bispecific T-cell engaging therapies as immunotherapy and immunoconsolidation for newly diagnosed multiple myeloma. As you know, the paradigm treatment for multiple myeloma nowadays involves a quadruplet-based therapy upfront for most patients. And most patients do well, but still about a third to a half patients don't attain that very deep MRD negative remission. So when we say MRD negative, we mean 10 to the minus 6 sensitivity. So to be able to detect one bad cell out of a million. So that a lot of times those patients would definitely move on to get high dose chemotherapy with melphalan usually and stem cell rescue. We call that autologous transplant. The idea of the immunoplant was to see if we can use fixed 4 cycles of a bispecific therapy called linvoseltamab to kind of drive those responses to MRD negativity. So originally the trial was designed for 25 patients. It met its initial first stage futility. And here at ASH, we presented as of November 1, 2025, our updated data where all 25 patients have been enrolled. 19 patients have received at least 4 cycles of treatment. And the overall summary of the responses is that of the 18 patients who were evaluable for MRD negativity, all 18 patients have attained MRD negativity. So the rate obviously is 100%, which is fairly profound, as you can imagine. Of those patients, 10 of those patients have actually made it to the 6-month bone marrow biopsy milestone to confirm that they're still MRD negative, and all 10 remain MRD negative after 6 months. So just to remind people, the way the trial was designed was there was fixed 4 cycles of therapy. Some patients received a 5th and a 6th, but so far only 2 patients required the 5th and 6th cycle. But the point is, after the linvoseltamab immunoconsolidations, patients moved on to standard of care maintenance treatment, which in most cases was lenalidomide therapy.
Finally, we focus on the use of T-cell engagers in relapse refractory disease. Shahzad Raza shares updated results from the RedirecTT-1 trial of talquetamab plus teclistamab in relapse refractory multiple myeloma with extramedullary disease. This is followed by Luciano Costa, who discusses initial results from MajesTEC-3, a trial comparing teclistamab plus daratumumab to investigators' choice of daratumumab and dexamethasone with either pomalidomide or bortezomib. And to complete the podcast, Amrita Krishnan will discuss the updated efficacy and safety of J&J 5322, a next-generation trispecific antibody.
This is an exciting study. Patients who have extramedullary disease, they have a very bad outcome. Current standard of care means that they have survival is only less than 6 months. Many of these patients, either they get single-agent bispecific therapies, their responses are very suboptimal. So there is an unmet need on extramedullary disease, how best we can treat. And this is the first study that I've been seeing that the patients who have extramedullary disease or asecretory myeloma with extramedullary disease, which are typically excluded from the study, we have seen some unprecedented responses by combining the two bispecific together, teclistamab and talquetamab. So this is an extension study. So we have like 90 patients enrolled in this study, and we have used the two bispecifics together every other week. And those patients who achieve the VGPR, which happens after the 4 cycles, these patients will go into once a month treatment. And then what we have seen that the responses are lasting quite significantly. More than 50% of the people are still durability of the response lasting more than a year, and overall survival has not hit the median. What we did differently in this study is we defined the extramedullary disease into different categories. Like organ EMDs, means the patients who have extramedullary disease involving the liver, involving the kidney, or non-organ EMDs, like patients who have lymph nodes involvements. So we separate those two categories and also did some volumetric measurements, like those who have 25 centimeter square volume or 50 centimeter square volume. So we try to divide these EMDs into different categories and assess the response. So our responses are quite significant across all organ and non-organ EMDs. So I think as a clinician, it's a wonderful thing for our patients to have that, because EMD patients are the one that is an unmet need. And I'm so glad to see the results come out in a positive way that our patients will benefit from this study.
So hello, I'm Luciano Costa, myeloma physician, University of Alabama at Birmingham. At ASH 2025, we had a late-breaking abstract coordinated with a simultaneous publication in the New England Journal of Medicine of the primary results of the MajesTEC-3 trial. So this was a large randomized global trial enrolling patients who had multiple myeloma with 1 to 3 prior lines of therapy, who had been exposed to a proteasome inhibitor and lenalidomide, and turned out the vast majority, over 85%, were lenalidomide refractory, and could or could not have received an anti-CD38 monoclonal antibody so long the disease was not refractory to it. And those patients, we usually use a CD38-containing regimen in that circumstances. So they're randomized between daratumumab-containing triplets, DPD or DVD, or daratumumab plus teclistamab or tec-dara. And this trial is reported now as the first interim analysis, and it shows substantial improvement in the primary endpoint, progression-free survival, with hazard ratio of 0.17, and a 36-month progression-free survival for the experimental arm that was over 83%. This trial also showed improvement on the experimental arm for every other parameter of efficacy, including complete response, overall response rate, MRD negative complete response. But quite a rare thing, it shows improvement in overall survival already with the first interim analysis, with a hazard ratio of 0.46. We saw quite overall comparable toxicity in terms of overall toxicity in grade 3 and 4 toxicity. There were a few more serious and fatal infections on the teclistamab dara than it was on the dara-containing triplets, but that excess in toxicity was mostly during the first 6 months and preceded the introduction of broader infection mitigating strategies that we all consider standard, like immunoglobulin replacement, growth factor use, PJP prophylaxis, and so forth. So we're all very surprised by the magnitude, by the effect size of the intervention here, the bispecific T-cell engager applied in second to fourth line therapy. And we believe the data is robust enough to represent a new standard of care. We saw this benefit does not seem to be restricted to any patient subset. Was seen across our stages, cytogenetic risk groups. Was seen for older patients with extramedullary disease, and was seen among patients who have received prior daratumumab therapy. We anticipate this study will yield to eventual regulatory approval, so we can give access to highly effective and safe T-cell redirecting therapy for patients as early as in second line, which is clearly a transformative intervention compared to what the options you had before.
So J&J 5322, first of all, has an official name now, romantomig, and it is a trispecific antibody targeting two antigens on the myeloma cell, BCMA and GPRC5D, and then it targets CD3 on the T cell. And the results we presented are on phase 1 trial, longer follow-up now than what was presented at ASCO. And what we show is that the response rate's 100% in BCMA naive patients. The median follow-up now is 14.4 months, and the 12-month PFS is over 80%. In regards to toxicity, the toxicity profile seems favorable. The grade 3, grade 4 infections plateau after 1 year of treatment. And also the GPRC-related toxicities in terms of dysgeusia, weight loss seem significantly less than what we've seen with talquetamab, the single GPRC targeting bispecific antibody. So, also just ease of use. This has a single step-up dose and a Q4-week dosing schedule. So in terms of efficacy, certainly very promising results. In terms of safety, also the signal seems very good. And in terms of, options for outpatient dosing and convenience for patients, also it really looks like it has some exciting options.
That's all the updates we have for you today. We hope you enjoyed this episode. Head over to vjhemonc.com to see our full coverage of ASH 2025. Be sure to follow us on X at VJHemonc and subscribe to our podcast on Spotify, Apple, or Podbean. Until next time.